Atherosclerosis and renal failure. Letter of referral. Dear Dr. Mr. Harry Scott, aged 65 years. Please would you see this man? He is a heavy smoker and has been hypertensive for 10 years. 1 month ago he was admitted to hospital with chest pain and a suspected acute coronary syndrome. His troponin was not elevated. He was started on an angiotensin-converting enzyme, ACE, inhibitor, and he was put on the waiting list for a coronary angiogram, not yet done. I was asked to check his renal function, and this shows that his creatinine, which was normal when he was discharged from hospital, is now markedly elevated at 260 micromoles/L. What should be done about this? Yours sincerely. Introduction. Renovascular disease is an important cause of renal dysfunction and resistant hypertension. In patients with atherosclerotic renovascular disease there is usually evidence of cardiovascular, cerebrovascular, and peripheral vascular disease. History of the presenting problem. Renovascular disease. It is very likely that this man has this condition, which produces no specific symptoms. However, it is worth asking the following questions. Has he felt dizzy and been hypotensive since starting the ACE inhibitor? Hypertension related to renovascular disease often responds dramatically to ACE inhibitors. Has he had episodes of sudden onset severe shortness of breath suggesting flash pulmonary edema? Renovascular disease can cause such problems, which may have been better since starting on the ACE inhibitor, but this is uncommon and episodes of breathlessness are generally much more likely to have a cardiac explanation. Other vascular disease. There is a strong association between renovascular disease and peripheral vascular disease, so probe carefully for symptoms suggesting intermittent claudication, amaurosis fugax or transient ischemic attacks. NB. The best predictor of renovascular disease is evidence of peripheral vascular disease. Other causes of acute renal impairment. It is very important to consider other possible causes by pursuing the following aspects of the history. Prerenal failure. Find out if the patient has had any illness since discharge from hospital that would predispose him to this, for example diarrhea/vomiting or any symptoms that suggest volume depletion, e.g. postural dizziness. Urinary obstruction. Has he had any difficulty passing urine, any back pain, any hematuria, or passed any stones? Renal inflammatory condition. Has he felt unwell in any way? Systemic features, fever, etc., are not expected with renovascular disease and could support a diagnosis of prerenal failure or a renal inflammatory condition. Has he noticed any skin rash, particularly on the feet? This may suggest cholesterol emboli, or if it is more widespread may be due to drug hypersensitivity associated with acute interstitial nephritis. Relating to the latter, has he taken any other new drugs, including over-the-counter medicines, the commonest cause of acute interstitial nephritis? Has he had aching muscles? He will almost certainly be on a statin and could have developed rhabdomyolysis. Has he had any symptoms that might suggest a multi-system disorder, e.g. joint pains or nasal/sinus problems? Other relevant history. Patients at risk of renal atherosclerosis have the same risk factors as patients with atherosclerosis at other sites. He smokes, but is he diabetic? Plan for investigation and management. Given the high index of clinical suspicion that this patient has renovascular disease with acute deterioration in renal function caused by the ACE inhibitor, your immediate action should be to stop this drug, which may lead to improvement in renal function. Urinalysis. Significant proteinuria, more than 1+, and or hematuria, more than trace, would not be expected in renovascular disease. If present, consider cholesterol embolism or other renal inflammatory condition. Blood tests. Check renal function. Is this getting worse? Has it stabilized or is it improving? Check FBC and clotting screen. This man may require an interventional procedure. Inflammatory markers and myeloma/autoimmune/vasculitis screens depending on clinical suspicion. Urinary tract ultrasonography. This is the first-line imaging test in any instance of unexplained acute deterioration in renal function. In this case, look particularly for a discrepancy in renal length greater than 2 cm, which is strongly predictive of renovascular disease. Ultrasound will also exclude obstruction. NB. Urinary tract ultrasonography should be performed urgently in any patient with unexplained acute deterioration in renal function. Imaging for renal artery stenosis. The standard screening test is magnetic resonance angiography, proceeding to angiography, which remains the gold standard for diagnosis and also enables therapeutic angioplasty/stenting. Management. The following are essential. Stop smoking. Aside from general vascular considerations, smoking is an independent risk factor for the progression of renal disease. Aspirin and cholesterol lowering, statin, to reduce cardiovascular risk, although it is not proven that they influence progression of renovascular disease. If renovascular disease is proven, then consider dilatation and or stenting. Further discussion. Which patients should have occlusive renal artery lesions dilated and stent? This is controversial. Although benefit is unproven, it is technically feasible to dilate and to stent discrete stenoses in the renal artery. Most nephrologists would recommend angioplasty for bilateral stenoses with acute deterioration in renal function, especially in the context of ACE inhibition. Small kidney on one side and tight stenosis affecting the opposite kidney. Episodes of flash pulmonary edema not explained by left ventricular dysfunction.